And his viral load wasn't available then, but let me, I thought I wrote that down. It was, I did get a viral load. It was 174,000. And so it may be later in this, not. Okay, so it just, in his, he was incarcerated for a time, and so it was in that lab work from the jail that he was in that I got his initial viral load, and then I got the second one to confirm that it was chronic, and it is. And so he is currently in the COAT clinic with medication-assisted therapy. In fact, he has just moved to my COAT group, which meets every other week. So he's doing well. He smokes, but rarely uses alcohol. He is being treated at HealthRight for depression. He's doing one film of 12 milligrams of buprenorphine daily. So that's keeping him well controlled, and he's pretty compliant with things. We can scroll down a little bit. Yeah, keep going just a little bit more. And I started the vaccination process with him. So he's had his first dose of Hep A and Hep B vaccinations. Scroll down just a little bit more. There's really nothing outstanding in his lab work. A little bit more. So like I said, his genotype is 1. I did calculate his APRI score, which was 0.747. So that's not anything to write home about. Let's scroll down just a little bit more, keep going. And then his FIB4 was 1.23. And I guess my question would be, is there a better choice than Maverit? Since he's on, since he is a Medicaid patient, or anything else I should be doing for him, with him. On a physical exam, there's no tenderness, no liver enlargement noted.
Awesome. Thank you so much, Sue. That was an awesome case presentation. Before we jump into any of the recommendations and feedback, did anyone have any clarifying questions or comments for Sue? Feel free to unmute or chat in. All right, and anyone with recommendations? Feel free to unmute as well, any of the hub members.
Hey, Sue, this is John.
Hi.
And I should have responded when Mitra asked if anyone had questions, because this is a question. Do we trust this 1.5 years ago was when he actually acquired hepatitis C? Was that his only time when he used injection drugs, or what his risk factors might be?
No, not necessarily. I guess I really didn't inquire as to the length of time that he had used IV drugs. That was the first that he had been diagnosed with Hep C. And so let me pull up his chart real quick, just to make sure I'm answering you correctly.
Sure, yeah, and as you're looking for the answer, the concept that I was going to talk about was, you know, if he'd only had risk factors for 1.5 years, I don't think there's any need to really look for more advanced fibrosis. We'd sort of settle on what we have and go from there. If he maybe had risk factors that were 10 years ago, 15 years ago, 20 years ago, that APRI, remember 0.7 is our cutoff, and I'm going to read it read what the cutoff says. So it says blah, blah, blah. APRI score greater than 0.7 had a sensitivity of 77% and specificity of 72% for predicting significant hepatic fibrosis. So clearly, just looking at this guy, CBC, he does not have anything that suggests cirrhotic process. And that's not what the APRI would maybe be saying here, but saying, is there scar tissue, question mark. Now, this has nothing to do with his regimen selection. I agree 100% with your Maverick. I love it. I think it's a great choice. It'll be 8 weeks and done and all happy. But it really has to do with if he has scar tissue significant, F3 or greater, this is someone who will need long-term HCC screening. And so he does have a bit of an ambiguous APRI. So 0.7 being that cutoff. So, and things you can use as tiebreaker when you have an ambiguous setting. Number one could be clinical history. If it really has only had a year or two of Hep C, then I'm not worried about it. But if he does have maybe 10 years, 15 years with this ambiguous APRI, I probably would suggest serum biomarkers or elastography, just simply to identify a patient who might need long-term HCC screening. The most devastating thing I've had to happen in the, now 15 years of caring for people with Hep C is someone who's treated, cured, and then develops HCC afterwards. So remember that that establishment of fibrosis, Kaylee touched on this really well last time, is still so significantly important because it's the scar tissue that's oncogenic. So, but that's all.
So if I got a fibrosis test or FibroSure or elastography to confirm the status of his liver, then does that negate ongoing HCC screening?
Yeah. If he's got F1, F0, F1, F2, you're good. Those people, once you treat them, if they don't have significant fibrosis, their chances are pretty close to population baseline risks for HCC development. But scar tissue going forward, F3 or genuine cirrhosis, you do want to offer those people HCC screening.
And which would you prefer of the two, elastography or FibroSure?
Yeah, well, I got a hepatologist on here. I'm gonna punt Gene, but my own personal. I always say all of them, I'm a little nervous about elastography in this guy because he's a big fella. His BMI is 40. You might get some fatty liver, whatnot going on in there. But Gene, what do you think?
Well, that's actually what my presentation is on today. So the short answer is, your elastography has an 87% efficacy rate to diagnose cirrhosis, but the downfall of an elastography is truncal obesity, alcohol use, and the accuracy of the person performing the test. So it's usually better to use all of the tests and take them all into account. The FIB4 test is a great marker, but it's only 77% accurate.
Okay.
The APRI is only 7% accurate. So that leaves people that can sort of fall by the wayside, that sort of get lost. So it's better just to look at all of the tests and cross all your T's, dot all your I's.
Perfect. I will get those tests. Does that preclude starting treatment, or I can just get them and start treatment? And
I would think so, yeah.
Yeah, I would have no hesitation to treat him ahead of time. This is more a consequence of, or I should say, it implies long-term screening.
Right.
You're not worried about, the only thing you'd ever want to establish fibrosis ahead of time is if you're worried about somebody having a decompensated cirrhotic, at which point protease inhibitor-based regimens may be a bit of a worry. But obviously this guy, that's not a worry. The only other thing you'd want to do is, since he's only been sober for, 100 days or something.
Oh, he's up to 134 days now.
Yeah, heck yeah. It's, I'd punt it to him, make sure he's, you know, if you ask him the question, is now the best time to treat your hepatitis C if you're allowed one treatment for lifetime? Do you think the sobriety is going to be stick, or are you going to be at risk of relapse, etc.? You know, put that on the patient after you educate them on the one treatment for lifetime concept from most insurers, and allow the patient to participate in timing decisions.
I'll do that. And just with this caveat, you know, that he really is motivated, wants to get rid of this as part of his sobriety treatment, and, you know, in getting back to where he used to be. And so he's anxious to put this behind him, along with drug use and whatever other nefarious things he's done in the past. He's anxious to put that all behind him. So
sounds like perfect extra motivation to keep him in a good place. So I love it. And thanks for presenting him, Sue.
Sure. Kaylee, did you have any questions for me?
I don't. I think you did a great job. I just want to highlight, you know, the very beginning when Dr. Gilfus wanted to, you know, kind of know his risk factor history. You know, there's this concept of simplified hepatitis C treatment, and it's actually in the guidelines where you don't need to order all of these tests. You can basically just get basic lab work and then go ahead and treat. And that concept is really towards the HCV elimination strategy. So if you have somebody that's in a really good spot, just may have made bad decisions a year ago and acquired Hep C, you don't necessarily need to do such a comprehensive workup that we just discussed. You know, for insurance purposes, Medicaid's going to want to either have a fibro test or an elastography. They'll want that fibrosis number, that staging. But if you had somebody that was not insured, was in a good place, you know, young person that just acquired this pretty recently, you don't have to order all this testing. You don't even necessarily need to get a liver ultrasound unless they've got a lot of transaminitis or other risk factors for disease. You can just do an APRI and a FIB4, and is making sure everything's got a good reassurance that there's not any cirrhosis, but you wouldn't expect cirrhosis to happen that quickly in someone that's just got Hep C. You know, the things with this guy, again, highlighting he's about 40, but if he's had a long-standing drug use history and could have had this for a long time, plus he's got, you know, he's obese, so he's probably got that fatty liver, and he's got a little bit of transaminitis. His FIB4 does have actually a really high negative predictive value. So that if it's less than, I think it's 1. I got to look back because I don't know off the top of my head, less than 1.5 is a 95% negative predictive value for advanced fibrosis. So that's reassuring. But in the context that the APRI is elevated, he's got these risk factors, he is somebody I would make sure you're doing a good comprehensive fibrosis assessment. But just kind of for everybody on the call, just kind of keeping the idea in your head of, you know, what's this patient's, what are we treating? Is it somebody that's just recently exposed, or is it somebody that might have had this and could have that fibrosis established? But great case. I think that was a good welcome back, Sue.
Thanks. It's
Thank
nice
you.
to be back. Great gun.
Yeah.
All right. Thank you.
And Sue, did you have any other questions about this case before we go to the next one?
No, that tells me everything I need to know for this guy.
Excellent. Sounds good. All right, I'll turn things back to you then.
All right. So this one is a 40-year-old female. She had a viral load of 1.76 million, but her liver panel was fine. It was unremarkable. She's had it for about 14 years now, and she got it from shared IV drug use, and got it from a friend that she knew had Hep C and that she was sharing needles with. She's been incarcerated multiple times, and that's probably my biggest concern with this patient. She denies alcohol use. She denies drug abuse at this point. She has the usual anxiety, depression, hypothyroidism that could all be coming from the Hep C. And so I think she would benefit well from being treated, but I do worry about her because she's been in and out and in and out of prison. I would worry about her. She has been vaccinated with Hep A and Hep B. And in fact, I ended up giving her like a booster dose because we didn't have any confirmation. But then once we got her prison records, discovered that she had been fully vaccinated in prison. So now she's had a booster. We can move on down. She is a large female. Her BMI is 40.6. Her APRI was 0.417. She's a genotype 1A. Her FIB4 was 0.88. Her hemoglobin A1C is good. So you'll notice that these labs were from August of 2020, and then she sort of fell off the grid. And so I wondered what had become of her. She wasn't coming back in for her follow-ups. Well, it turns out she had been incarcerated 2 more times in between then and coming back. And so that's why she had not come back in and followed up with anything. And so I'm wondering about, that's why I'm wondering about that. So my questions would be, do I need to repeat any labs? Here again, with a history of about 13 years of having it, do I need to get a FiberSure or a elastography or right upper quadrant ultrasound, either one? And is Maverick a good choice since it does have West Virginia Medicaid?
Excellent. Thank you so much, Sue. Another great case. Did anyone have any questions, comments? Anyone from the group, feel free to unmute.
Hey, Sue, this is Kaylee. Do you know if she currently has any outstanding legal charges? If she's facing any jail time or on house arrest or probation, anything like that?
I don't. I didn't think to ask her if she was on probation or anything. She just mentioned that she had been non-compliant. She just had not shown up for court, and so I think that's why she ended up back in jail again.
Sure. I'll tell you my approach with patients that have had, recent incarceration or multiple incarcerations. I always ask them if they have any outstanding charges, if they're facing any jail time again, or just like you said, if they have a history of not showing up for court, and express to her that's one of the hesitations for you treating, is because if she starts treatment and has an interruption because she has to go back to jail, that could compromise her treatment success. I literally yesterday just had a patient who was in the clear with local charges, but actually just got indicted for out-of-state charges, and so was going back. And I'll tell you, had just started treatment, it was halfway through. If she does opt to start, make it very clear that if anything happens to where she's facing, make sure her probation officer or family member or patient themselves can contact you right away, and go ahead and tell them, bring their medication supply with them. That way, that's what I had this guy do. I said, just take it with you to jail, and then we'll call you tomorrow and make sure it's getting dispensed and there's not any interruption. But that's the biggest thing, is that if somebody can't get their medication to them, they're not going to just fill it for them. So I think that's a great point to make, and a great hesitation. But just to clarify, making sure she doesn't have anything outstanding, or if she does, that she knows how to get a hold of you quickly and knows to take her medication with her.
Okay.
In the case that you just mentioned, I mean, certainly, with a fibrosis assessment, I'd follow the same pattern with her, because she's probably had this, like you said, for some time. And even though you just got labs with her or for in August, I tend to get them about every 6 months or so, especially if they've had Hep C for a while, because even if 6 months ago there wasn't necessarily any fibrosis, once it starts, it can really progress non-linearly. So she can jump several stages, just in a matter of years. So I would go ahead and get a updated panel on her, and then also consider fibro test and imaging with her as well. Pregnancy is another thing. I don't know what her status is, but making sure she's either on contraception if she's still childbearing, or if make sure you clarify that, and make sure getting a pregnancy screen before she starts, since we don't have anything approved. But probably in her case, Maverick's going to be a better choice, just because it's a shorter course of therapy. And if you're worried about potential incarceration or falling out of care, then at least she's got that succinct treatment course.
Okay.
Good case. Thank you.
Thank you.
Any other comments, questions, or feedback, Dr. Gilfus?
Yeah, I had one little thing that I just learned this week on another hepatitis C call, and it eliminates a bit of a concern about checking things like FibroSure. So FibroSure is probably one of the most expensive tests, like lab tests we order. When I just Googled it, it says it's average charge is about $500. But Medicaid has no restriction, and this came from the Medicaid director this past week. They don't care how often you check it, and so they're not going to penalize you for checking. A lot of times in these talks, we advocate that you check a FibroSure maybe yearly on untreated patients, unless there's risk factors for advanced fibrosis, like Kaylee mentioned, or accelerated fibrosis, where every 6 months is probably smart. And a question from a caller in the other Hep C talk was, is a patient going to get the bill for that? And the answer is no. Medicaid will pay for basically any frequency of FibroSure. I wouldn't recommend trying daily. That'd be a bad idea. Limited clinical utility as well. But yeah, in this one, I agree 100% everything Kaylee said. And good job, Sue.
I believe the elastography is about $500. I think about $450, $500 as well. And so, I tend to kind of alternate them, and not necessarily get both of them every 6 months or so. But yeah, if you're following a patient and you're not treating them right away, you might want to just alter, so you're not always ordering both.
I think the viral load is fairly cheap. The PCR is not a lot of money. I think it's like $50 or something, but that would be the other thing you definitely got to keep an eye on for sure. Not that you expect late clearance, but usually insurance will want you to prove it's still there.
And Rachel might mention this too. I think with the viral load, I believe that you have to have that one within the last 6 months. And so, yeah, like John said, that's one you'd have to trend. And I'm not sure about genotyping. I feel like if you haven't had one for a while, you may want to recheck it as well. But I don't know if they have a restriction as far as how often that needs to be repeated. But if you've had one that's, more than a couple years ago or 5 years ago, and they have ongoing risk factors, you may need to repeat that too, or get it updated.
Yep, just like Kaylee said, within the last 6 months. And then we have had some go through from insurances are going to vary a little bit, but usually within like the last couple of years, like 2 years, Medicaid will approve those. But if they do have ongoing risk factors where they could have, multiple genotypes, it could be infected with other ones. Sometimes they will say, we should get an updated one, and they'll let us know that and just kind of pause the authorization while getting labs.
And did anyone else have any comments or questions? I know we have some new folks on here today, so I just want to reinforce that this is a safe space and you're more than welcome to chime in at any point. Ronald Greer, I saw you raised your hand. Did you want to unmute and mention anything, or was that by mistake? No worries if you clicked that by accident.
Rachel, thank you for that information. I realized as I was thanking you that I was muted, and then I couldn't find my microphone button to unmute.
Sure, anytime.
And no worries at all, Sue. That always happens to me. You don't know how many times I started a session when I was muted, so you're totally fine. It's the new norm. And thanks for chatting that in, Jen. Jennifer mentioned that it's really interesting information and actually helped her with a patient that she just finished with. So thanks for chatting that in, Jennifer. And Sue, were there any other questions you wanted to have addressed about this case? I think you might be muted again. You can try hitting the space bar too. Elizabeth taught us that.
Oh, I just always forget that I'm muted. You know, I mute it so that any noise from my end isn't causing a disruption in things, and then I forget. So, no, thank you. That everything was answered that I needed. So, thanks everybody very much.
Absolutely, and thank you so much for the 2 cases. We always love great cases, so we appreciate your time. Thank you. Alrighty, Jean, I have your didactic ready to go, so I'll just pull it up on my end and I'll turn things over to you anytime you're ready. And let me see. Is everyone able to see this okay? All right, awesome. Okay, Jean, I'll turn things to you. Thank you.
Okay, thank you. So just a little bit about myself. I don't know if everybody knows. So I only do liver disease. I've done liver disease now for about 15 years. I came from a transplant program in Dallas, Fort Worth at the Baylor Transplant Center there, and came here to work with Dr. William Hudson, who came from the Baltimore Transplant Center, with this grand idea that he's going to eventually do transplant liver disease here in West Virginia, which is kind of amazing, but kind of off in the distance, I think. But anyway, it's been a real challenge to me to sort of wrap my brain around rural West Virginia and to see how it all works. So it's kind of interesting to me to hear how, you know, everything works off in different areas, because this is, even Morgantown is really rural for me, for where I came from. So it's kind of cool. It's very different for me. So anyway, so my guiding, my training is all from AASLD guidelines, which is the American Society on Liver Disease, and also from the European guidelines for liver disease, so EASL and AASLD guidelines. You can flip pages. I don't know, how do I flip? Can I flip or do you flip? Okay, perfect.
I can flip it for you.
Perfect. Thanks. So on the next page, it actually says that AASLD guidelines recommend this, but, you know, from a liver disease standpoint, anybody with liver disease should have abdominal imaging from my standpoint. So it's very interesting for me to hear, you know, everybody in infectious disease saying, and, you know, from Hep C treatment and Medicaid and everybody saying that they don't need imaging, because from a hepatology standpoint, everybody needs imaging for everything. You know, if you have jaundice, you need imaging. You have, you know, elevated LFTs, you need imaging. You have pancreatitis, you need imaging. You can go ahead and flip. You can, there you go, thanks. So AASLD says that you start out with an ultrasound, and that anything beyond that, you know, if you have anything larger than like a 1 centimeter, it's actually 10 millimeters lesion, then you know, go up the scale to a multi-phase MRI or a CT scan. We don't really do non-contrasted CTs or non-contrasted MRIs. They're not diagnostic for liver disease. And that happens a lot here in West Virginia. So it's really interesting to me to see that. So I don't know if that's just a regional thing, or I don't know how that came about, but I was looking that up because I found it very interesting. So European guidelines and the American guidelines recommend multiphasic MRI, multiphasic CT scan. If you're going to do a cross-sectional, any kind of imaging, you want it to be multiphasic. Otherwise, we can do an ultrasound. Okay, you can go ahead and flip. So obviously, if you're going to look at that right upper quadrant, you're going to look at any and all of these things. You know, you can touch on all of this pretty much with an ultrasound. You really can't see bile ducts with an ultrasound. You really have to have that MRCP or an MRI in order to see that. You really don't see a whole lot of vascular flow. You can sometimes see arteries and veins, but you can't necessarily see vascular flow. You can certainly see that on a CT scan, and that's really nice because you can see a lot of thrombosis and such on CT scans. You can see that better on a CT than the MRIs. But for the most part, you can pretty much see all of this stuff on an ultrasound. Go ahead and flip. I threw this slide in here because I get a lot of imaging from all over the state. I get it from Ohio, Pennsylvania, and Maryland. And I always kind of chuckle to myself because sometimes I get liver, normal, spleen, normal, kidneys, normal. And I'm always like, what's normal? So, you know, I always wanted to read, you know, liver measures 15.3 centimeters, it's hypertrophic, or the left lobe, this, that, or the other, or the vascular flow is in the direct appropriate pattern or whatever. So it's always a little bit curious to me as to what the radiologists are looking at. You know, we depend upon, or I depend upon, the radiologist a whole lot when I read these reports and making these decisions on liver diseases, particularly for lesions. So if they say cystic lesions in the liver on an ultrasound and they say they're benign, unless they tell me where, how many, the size, what they look like, and what the capsule of it looks like, I'm not going to believe them that it's a cyst, because there's too high of a risk for liver cancer. So they have to really be very detailed. So that's why, you know, a lot of times we're insistent that the patient gets repeat imaging here at Ruby, which is probably very frustrating. I understand that. It's very frustrating for the patient. It's probably very frustrating for the providers. You know, they're like, hey, we just got this imaging. But it's just not, it's oftentimes not very detailed, and it's not real clear, or it's not contrasted. And so it kind of leaves us guessing, and that's just not safe for the patient. So we often get additional imaging. AASLD guidelines says that an ultrasound is negative if there's no abnormalities in there. So anything that shows fatty infiltration, that shows any increased size, that shows any changes in echotexture or nodularity or any lesion, anything at all is an abnormality, and that's a diagnosable disease. It's definitely considered concerning for a lesion if it's greater or equal to 10 millimeters, and that's concerning for an HCC until otherwise proven. Go ahead and flip. The LRAD system is, I don't know how new this is. It's fairly new, I guess. It's just a way of, you know, gauging these lesions, and we depend on this a whole lot in the liver system because, you know, this is how they grade our cancer lesions, and anything greater than a LRADS 3 is concerning for cancerous lesion. And LRADS 3 is sort of a wait and see kind of lesion. You know, we're worried that it's going to be a lesion that's cancerous. And LRADS 4 is certainly something that we're probably going to treat with some kind of a procedure, a TACE procedure, or some kind of a chemoembolization. LRADS 5 certainly is a cancer, and it's definitely going to be referred over to oncology. But for an LRAS 3 and 4, that definitely dictates how frequently we're going to do an MRI, or, you know, what kind of imaging we're going to do next. So these LRAD systems are pretty important to us. Okay, you can go ahead and flip to the next screen. FibroScans are fairly new. These are really kind of great. So as I mentioned a little while ago, they have an 87% accuracy for predicting cirrhosis, which is pretty amazing. They have even higher accuracy. I think it was like 89 or 90% accuracy for predicting non-cirrhotic liver fibrosis. So that's pretty amazing. You know, to be able to score something and say this is definitely it. Now there is a lot of variability on FibroScan, so we have to be careful with that. But the biggest issues with elastographies is that it's dependent upon the ability of the person doing it, obviously, the training that they had and the experience that they have doing it, as anything is. But it's also dependent upon the patient. So anybody that has truncal obesity is not accurate. You know, so if they carry all their weight in the middle, the elastography is not going to help you out. Alcohol use skews the results because alcohol breaks down as fat, and it enlarges the liver, and then it creates a necroinflammatory response, and it just creates a diffusional response and reflection on that sure wave elastography, so it skews that result. So alcohol, truncal obesity, and the ability of the person doing it. Those are the things that will alter your FibroScan. And I don't know how many were on the list, but it was very nice to see that list that Kaylee put out. I really appreciated that, of how many locations throughout West Virginia are doing elastographies. That was really nice. Go ahead and flip it, please. So non-alcoholic fatty liver disease and hepatitis C without cirrhosis, you can do a baseline ultrasound. If it doesn't look like anything that has cirrhosis, you don't need to do another one. You can pretty much, if you cure the hepatitis C and you're monitoring the labs and things are looking pretty stable and nothing really changes, there's no reason to do additional imaging from a hepatology standpoint. If you have fatty liver disease on top of that, and their A1C is controlled and their weight is fairly controlled, you know, they're not morbidly obese, and their hypertension is controlled, and, you know, their cholesterol and triglycerides are fairly controlled, there's no reason to repeat imaging. But generally speaking, I recommend like every 3 or 4 years, you might want to just do a spot check, do an ultrasound. They're cheap. Just see where that liver looks. If the echo texture has changed, if the echogenicity has changed, then, you know, you can always bump it up the scale and go from there. But for the most part, you don't have to repeat anything if they're non-cirrhotic. Go ahead and change. This is just a little bit of more information other than hepatitis C, but for fatty liver, you can get a lot of secondary causes of fatty liver in the liver. So hepatitis C genotype 3, interestingly enough, causes fatty infiltration into the liver. Alcohol does, as we mentioned a little while ago. Wilson's disease does, that's a genetic disorder. Starvation does. So these people that are morbidly obese, they have a gastric bypass or a sleeve gastrectomy, and they lose, you know, 100 pounds in 3 months. If you check their imaging, they look like they have fatty liver despite losing all this weight. And it's because of the starvation effect. Their LFTs will often go up, and it'll look like they have fatty infiltration, which is a new onset for them. And it's just because the liver is having to work extra hard to metabolize all the extra breakdown within the body. So starvation and nutritional deficiencies will look like fatty infiltration into the liver. Medications are notorious for this as well. Amiodarone, nitrofurantoin, I didn't put that one on there, but that's another one. Methotrexate, everybody knows about steroids. And then of course, you know, fatty liver, pregnancy, and HELLP syndrome. Okay, you can go ahead and flip. Cirrhosis, we always start with the basic ultrasound. If they don't have any liver cancers, we do it every 6 months. The reason we do it every 6 months is because we're screening for liver cancers. They have a very, very high risk. Hepatitis C is the highest risk. Well, no, Hep B is probably the highest risk for cirrhosis development. HCC development in cirrhosis, and then followed by hepatitis C. But we also see people getting, HCC that has fatty liver. We see people that are developing it with other random things like PBC and autoimmune. So it's just prudent to constantly follow them with an ultrasound. I usually alternate ultrasound, MRI, or a CAT scan every 6 months. So they get some kind of cross-sectional once a year alternated with an ultrasound. Okay, you can go ahead and flip. The bile ducts, like I said, they can't be seen usually on an ultrasound. You need the MRI, MRCP, or an MRI pancreas protocol. This always goes through, we can start the process, but it always ends up going through the advanced endoscopy program here through our department. Okay, next one. The vascular disorders or the thrombosis that we get, this is a pretty common finding with cirrhosis. The vascular flow into the liver because of the scar tissue is often impaired. Just because of the scar tissue. And so because of that, we get this turbulence of the blood flow going in and then sort of a churning effect. And because of that, you get an increased risk for clotting. The only way you can see these clots is usually on a CT scan. You won't pick it up on an MRI, and you won't pick it up if you don't do a multiphasic CT scan. So it gets missed a lot on these non-contrasted imagings. We don't recommend doing antiplatelet therapy on people with cirrhosis. They bleed and they die. So if they have a portal vein thrombosis, unless it's in the SMV, we don't recommend antiplatelet therapy. That's just something to think about. We don't want to put them on blood thinners because they're already thinned out because of the liver. Okay. These are just two examples. This is the same guy, CT scan without contrast that he had done at one facility, an MRI with and without that he had done at another facility. He had liver cancer, a huge thrombus. The guy actually died from this. It's unfortunate because he clearly had this for a very long time and it was missed. And it's just kind of sad because the imaging just wasn't the most appropriate one. So it just really got missed. But as you can see, like on the CT scan without, it just shows on the liver mass, there was a 5.4 centimeter calcified mass in the right liver lobe. It's partly exophytic. It doesn't talk about vascular structures at all or the biliary tree at all. On the MRI with and without, it tells you on that liver mass, it's hyperintense. It has some hypointense lesions. It tells you a different size. It tells you it's in section 8 of the liver. It has restricted diffusion. It has arterial enhancement. It's an LRADS 5 classification, so it tells you it's malignant. It tells you the arterial phase of the vascular flow has a chronic occlusion. So, it gives you so much more detail. And if this had been found 6 months or 9 months earlier, this guy could have been treated. He could still be with us today. Okay. Last one, same thing, details. Elastography, different locations. One is cirrhosis, one is non-cirrhosis. Again, it's just about terminology and you sort of have to learn to read between the lines. The one on the left, it doesn't give you a whole lot of detail, but the thing that I find the most disturbing about it is if you get a score and the score at the top says it's 2.61, classification severe. So this lady has cirrhosis, which aligns with the bottom scoring system, severe down there at the bottom, 261 falls into that. But if you took that number and you said, well, what if she's a 1.9? Well, if you look at that scoring system, she falls into 3 different categories now. They all overlap and it's unclear. And that's what I don't like about this particular facility that does these elastographies. So you have to be real careful when you start reading these things, they're kind of vague. And so it kind of leaves people with unclear results. And that's a little bit concerning when you're making decisions for these folks. The one on the right is a non-cirrhotic person. And the scale on this one has a little bit more detail, I guess. But the scale is what I like the most about the one on the right. The scale has absolutely no overlapping values. You're either in one value or you're not. There's no option to be moderate and severe, or, you know, it's very clear. So that's the biggest challenge that I have with some of the more off-site locations that do these things. And if I could go there and like transport myself over there and be like, hey, let's fix this. This is the one thing that I would fix is their scale. Please narrow the window so it doesn't overlap. That's my pitch. I have nothing else to say.
Thank you so much, Jane. That was a really great presentation and such really great information too. And I'll be sure to include it in the recap email so everyone has access to all of those slides. But thank you so much for your time and presenting. It was wonderful. Did anyone have any questions for Jane or comments or anything? Feel free to unmute or chat it and I'll be more than happy to read it out loud.
Man, Jane, this is Kaylee. I just have to sing your praises. You're so wonderful and you're just so great at teaching us because we don't get that hepatology side of things. So thank you so much. Everything with your talk, I've taken notes because you gave a lot of really, really good information for us. So thank you very much.
Thank you.
I'll second that, Jean. That was really educational, especially as a primary care provider. I don't know, you know.
Thank you. Thank you.
So thank you.
And I'm not even a clinician, but I can tell that you like worded that and taught that so well. So thank you.
Thanks.
Hey, Jean, I have a question. This is Kaylee again. I mean, you know, I feel like you and Dr. Hudson are really the only hepatology specialists in the state. So, you know, being that this is a call with multiple primary care providers throughout the state, what's an overall kind of threshold that you would want a patient to be referred to you versus, you know, what, because otherwise you're going to be getting every single liver patient in the state of West Virginia. So kind of what's something that, you know, what are some tidbits as far as when you feel like they need to be referred on, or even with your confidence in some, you know, just overall general GI practitioners in the state? Because I know hepatology and GI is a huge umbrella, and not everybody that practices digestive diseases is specializes in liver. So what are some of your thoughts or help with that, since I don't want to get you every single patient in the state, but that's a lot for you.
You know, that's a really good statement, because a lot of GI doctors are very, very uncomfortable with liver disease, I have found. So what I would say is, if you have people that have elevated LFTs, let me back up. Check the LFTs. A lot of people don't check LFTs apparently for a long time. Just check them periodically, because that seems to be missed, I think, a lot, because it's not on people's radar, I guess. So if the LFTs are elevated more than maybe double normal, so normal should be less than 50 on AST/ALT. If it's more than double and they won't go down, like you've checked them, you know, pretty consistently for, you know, a couple of months or whatever, and they're staying high and you can't figure out why, send them. I have no problem seeing them. But, you know, if they're 62 one time and the next month they're normal, or the next time they're 48 or something, you don't need to send them. It's probably that they're fatty liver and it's just, you know, they've gained weight or whatever. If they're just really barely elevated, they don't have to come up. But if you're uncomfortable with them, please send them. I'm happy to see them. I'll tell you what I think about them. If I feel like they need to come back, fine. If I feel like they don't, I'll tell you what I think that, you know, do with them. I have no problem with that at all. And you're always welcome to like send me a message or call me or whatever, and I'll tell you what I think about them too over the phone.
Or have a liver echo, hepatology dedicated echo. How about that? Thank you so much. That's super helpful.
Yeah, right. So that's actually something I talked to Dr. Hudson about talking about, well, we were talking about alcoholic cirrhosis, but more than just that, but we were talking specifically about alcoholic cirrhosis that day, about trying to teach people what to do with alcoholic cirrhosis, because I think that's a real big stumbling block for a lot of people. They don't know what to do with these people.
Jean, I have a question that it's kind of, in my mind, it's imaging in the opposite direction of how you presented it. So if I have a patient who has gotten a abdominal CT scan for other reasons, I'm not even sure why she got it, and it shows fatty liver on the CT, but that's all it says. And her LFTs are normal, and do I need more imaging to further delineate that, or can I just watch her LFTs and have her, do risk factor modification on it?
You don't need more imaging. What I would tell her, if her LFTs are normal, I would look at all of her metabolic syndrome stuff and tell her she needs to address all of that stuff.
Thank you.
Yep.
It's good. That's what I told her.
Perfect.
I have a question. And I put it in the chat box to Kaylee, but maybe some others have seen it too, that I have a patient who has Hep C co-infected with Hep B. I referred this patient to infectious disease. Was that the right place to send this patient, or should I refer to you, Jean, or to GI?
You know what? I think there's a lot of overlap, because I end up seeing a lot of Kaylee's patients. They treat them, or they get them on medications, or they're doing imaging or whatever, and they find that they have cirrhosis or something, and then they refer them to me. So either way, I think is fine. I don't know how they feel about it, but I feel like there's a lot of overlap for our program. So I have no problem with either way.
Okay.
Yeah, I'm the same way. This is Kaylee. Yeah, we usually if a patient has other causes of chronic liver disease, or they have cirrhosis, I think they should at least be evaluated by GI. But if you have a co-infected patient, we can always do that workup. And then if they've got, more advanced liver disease or need kind of chronic liver workup, then I can always send them off to hepatology too. A lot of times the referral kind of comes to us both, and then whoever has openings first is who they get scheduled with, is kind of what my experience has been.
Yeah.
Yeah.
Thank you.
Dr. Rexroad?
I was just waving. We've got a patient ready, so good to see everybody, and it was a great presentation.
Thank you. Glad you could make it today. Were there any other questions or comments or thoughts that anyone wanted to share with the group? My phone says it's 1:12 p.m., but my laptop says 1:15. So I don't know which one to go by. But if there are no further questions or anything, I just wanted to thank both Sue and Jean for a great session today. We really appreciate you all. And I saw over in the chat as well, Leslie, you had a great case in there. I'm sorry we didn't have much time to fully dedicate enough, sufficient time for that, but I'll email you and we can work to submit a case for next time with you. So thank you all so much. The only announcement that I have is our next session is on June 24th, and Carolyn Kidd will be discussing health and pain management. So keep an eye out for that reminder, and we'll see you guys next time. Thank you.
Thank you.